Shoulder injuries are one of the most common types of injuries that lead people to seeking out orthopedic care. Now, the shoulder is a highly mobile joint, allowing us to do a variety of different things, getting into different positions through a large range of motion. Because of this inherent mobility that we have, unfortunately, it's not the most stable joint. So it lends itself to being more easily injured than another type of joint similar in structure, such as the hip. The hip and shoulder are both ball and socket joints. However, the shoulder joint is a much more shallow socket. So when we look at the anatomy of the shoulder, we need to get familiar with all the different parts and pieces, and we'll start with the bones. And when we talk about the shoulder joint, we often refer to the glenohumeral joint. The glenoid is the socket part of the joint, and that is part of the scapula, or the shoulder blade. The humerus is the arm bone, and that is what makes up the ball of the ball and socket. Now, these two bones fit together and they articulate very well, but they don't have a lot of depth to them, making it a more unstable joint. So we have another structure, and it's a piece of cartilage called the labrum. This wraps around the rim of the glenoid, and it provides more depth and more stability to the joint. Outside of the bones and the cartilage, we also have a variety of ligaments that surround the joint, and these provide more structure. Ligaments connect bone to bone, so they are designed with a lot of stability in mind. Lastly, we have a variety of muscles that surround the shoulder joint itself. 4 different muscles form the rotator cuff, and the rotator cuff muscles share a common tendon that encapsulates the glenohumeral joint. These 4 muscles are the supraspinatus, the infraspinatus, the teres minor, and subscapularis. They play a large role in obviously rotating the shoulder through internal and external rotation, but they also provide a large compressive force, almost acting like a suction cup for the glenohumeral joint, and this helps keep the humerus in the socket, so it helps reduce the likelihood of a dislocation occurring. In addition to the rotator cuff, other muscles that you will find in this general area are the deltoid, the pectoralis major, the trapezius, notably the upper trapezius, our latissimus dorsi or our lats, our rhomboids, and then there are a variety of other smaller muscles that attach to the scapula and help keep our scapula close to our rib cage. This articulation between the scapula and the rib cage is called the scapulothoracic joint. This joint is what allows the shoulder blade to move up and down. The shoulder blade can elevate, it can depress, it can retract and protract, and it can also have an upward or a downward rotation to it. When we think about shoulder motion, a lot of the motion does come from the glenohumeral joint or the ball and socket, but it also comes from the shoulder blade moving fluidly and smoothly on the rib cage. In addition to the glenohumeral and scapulothoracic joint, we also have our sternoclavicular and acromioclavicular joints, and this is where our clavicle or our collarbone comes in contact with our sternum and with the top part of our shoulder blade or our scapula. So when we look at the shoulder, think of it more as a shoulder complex with a variety of joints, and don't get too tunnel vision just on the glenohumeral joint. Rotator cuff injuries are one of the most common categories of injuries that you will see when talking about the shoulder complex. Now, we mentioned the rotator cuff is 4 different muscles that help control and create movement throughout the shoulder, and they also play a role as a dynamic stabilizer for that glenohumeral joint. Knowing this, common mechanisms of injury and how people are going to irritate and potentially injure that rotator cuff are often associated with throwing or overhead motions, contact, impact, or direct trauma to the joint, falling on an outstretched arm when an individual tries to put their hand down to brace their fall, or it can just come from repetitive stress and wear and tear over time from doing the same types of motions over and over and over. With rotator cuff injuries, if we're talking about a rotator cuff tear, this can happen and it is graded in 3 different ways. So they will give it a grade 1, 2, or 3 categorization, 3 being the most severe, 1 being the least severe, and 2 being somewhere in the middle. The type of tear that you have and how severe it is often going to be dictated by how much is actually torn. If we have a full thickness tear, a full rupture of the tendon, that's going to be categorized as a grade 3. It means that it is no longer intact. And with this, we have 2 options. We either deal with it or we go in for surgery. That decision is often going to be based on what your overall functional status is and your level of pain. A grade 1 injury means that the fibers have been stressed, they have been stretched, there might be some small tears, but it is still largely intact. With these, they are obviously less severe, so they do not require surgical intervention most times, and they will resolve on their own with guidance and a structured rehab program and activity modification. Overall symptom levels tend to be less severe, and they tend to clean up a little bit more quickly and a little bit faster. A grade 2 injury means that yes, there is a definitive tear, but it is not a full tear, so it's categorized more as a partial tear. You can think of this as somewhere between 25 to 75% of it has been torn, but it is still structurally intact. With these, there is often more pain than a grade 1. There is going to be more loss of range of motion, strength, stability. You may be apprehensive to do things at times, but because that tendon is still intact and because that muscle is still intact, you are able to try to regain full strength and full range of motion, and this can be possible. Everybody's a little bit different though, so your progression in regards to how much of that comes back and at what rate it comes back is going to vary from person to person. This is where MRI imaging and consulting with an orthopedic and getting their impression on what they think your ceiling for potential is and what the best route to entertain is going to be a very important part of that process. And that way you know when you're going in for PT and going in for rehab, can you expect a full recovery? And if so, what's a general time frame that they think this will occur? But in general, we can expect physical therapy to focus on symptom reduction, which is often accomplished through activity modification and educating the patient on what positions, movements, and activities are going to be beneficial versus harmful at different phases of the rehab, restoring mobility. And those mobility deficits or limitations are often going to be linked to the severity of the tear and where that tear is located, and then also regaining back full strength and stability of the shoulder. And what we are most weak or limited with is often going to be dictated by the location and type of tear as well. And that is primarily going to dictate exercise selection and exercise progression. As we see a reduction in pain, an improvement in mobility, and gains in strength and stability, our overall functional status and ability to do activities of daily living, occupational demands, and return to our leisure and recreational activities will all go hand in hand and progress in not a perfectly linear fashion, but a progressive fashion week by week and month by month. In this video, we're going to highlight 3 common strength-related exercises with rotator cuff rehab. And with those 3 exercises, we're going to show some different variations with each one. So what may be a more remedial version or a more basic version of that exercise? And then how does that basic and foundational exercise translate into a higher level task down the road? So we're going to look at resisted external rotation, commonly used with a simple TheraBand or resistance band. We're going to look at a rowing or a pulling exercise, and we're going to look at a pressing or a pushing exercise. Pressing and pulling are 2 foundational movement patterns that are often introduced early on in the rehab process and then built upon all the way back to later phases of rehab, whether it's returning to work or high-level sports competition. So common exercise that you'll find in rotator cuff rehab is resisted external rotation, which I'm doing right now. This can be done with a cable column, or you'll often see it done with a TheraBand or resistance tube. Keep in mind, a TheraBand or resistance tube is going to increase resistance as you create more tension, whereas with the machine that we have that is plate loaded, it's going to be a set resistance regardless of the range of motion you're working through. Both have their advantages. Now, this may be too challenging for some people, so a more remedial version that you can start with is just an isometric walkout. So with this, I have my elbow pinned to my side, my arm is bent to 90 degrees, and I am just holding this position right here. The resistance is trying to pull my hand in, and I meet that resistance. Now, to make it a little bit more exciting, you can add a small walkout. So have them take a step out and then a step back in. With this, it's going to stay constant, but they still need to coordinate, maintaining the position with their shoulder as they are stepping in and out. We don't want to see the hand fall in as they step in and out. We want them to be able to maintain this position. If the isometric walkouts become too easy, another activity that you can do that is isometric for the rotator cuff, meaning that no movement is happening through internal or external rotation, but we are going to introduce some movement in a different plane, we can do a variation of a Palloff press. Now, most of the time when we think about a Palloff press, it's both hands reaching in and out, and the band is trying to pull us across. For this, to make it a little bit more specific to the shoulder and the rotator cuff, mainly external rotation, we're going to have just one hand on the handle, and we're going to have the same starting position as our walkout, but we're going to reach out, punching motion, and then come back in. So we are trying to resist the urge of the band to pull the arm across, and we want to stay right in this plane of motion right here. Have the individual perform 8 to 10 punches in and out, maintaining that nice, smooth and controlled motion, going out and in. So at this point, the individual is probably ready and able to do the traditional resisted external rotation. When that becomes too easy, we can make it more challenging by going through a larger range of motion and adding additional body parts and motions beyond just isolated external rotation. One of my favorite things to do is to do more of a cross-body row or a cross-body pulling pattern that has external rotation as a piece of the puzzle. So for this, position with feet wider than shoulder width. The athlete's going to reach across with their palm down, weight on this inside leg. They're then going to pull across their body and extend the arm. We're weight shifting from our inside to our outside foot, so we're getting lower body involved. We have a pulling motion, but we also have rotation happening at the shoulder. With the hand, you can start palm down to get more exaggerated internal rotation and finish palm up to exaggerated external rotation. So another common exercise that you'll find will be a resisted row with rotator cuff rehab. And this can be done with light resistance using a cable column or with a resistance band or a TheraBand early on. With this, we can make it a little bit more involved and a little bit more challenging by changing the stance that they're in and asking them to go through a little bit larger range of motion. With this, I like to have them in a staggered stance, and whatever hand they are holding on with, the opposite leg is going to be in front. So if I'm holding with the right hand on the handle, my left leg will be in front. With this, we're going to have them reach forward, almost like they're trying to touch the machine. When this happens, they are going to feel more weight onto this front leg. With this motion, we're also getting a larger range of motion by allowing them to reach out further and getting the trunk in a more forward flexed or upright position. So we're taking that isolated basic row and we're teaching them how to integrate that with a total body movement pattern. You can do this same exercise and change the angle to a high or a low setting. Something like a lat pull down, whereas a lower motion will have the athlete reaching down towards the ground and will keep the hand below the shoulder height, which may be an easier entry point for this exercise, keeping the hand nice and low as opposed to reaching above the shoulder. Keep in mind that you can have a low setting as an easy entry point. You can have a more chest height setting or an overhead position to get into higher levels of forward flexion and overhead stability demands. So we've gone over external rotation, we've gone over rowing progressions. Now we're going to go over a pressing or a pushing progression. Early on in rehab, you will often see an exercise called a serratus punch. Now, earlier in the video, we referenced that scapulothoracic joint, the shoulder blade moving on the rib cage. The serratus punch is all about isolating that motion. We are into a traditional dumbbell press. Then from there, we're going to progress into a medicine ball throw. All of these are pressing type motions, and we're going to start with something basic and isolated, take that through a larger range of motion of a full press. Then we're going to add a little bit more resistance and velocity or speed into the motion with a medicine ball throw. You'll start on your back, 2 dumbbells, 1 in each hand. Positioning oftentimes will be with the palms facing each other, but you may see it with palms down depending on how your PT coach injury. With this, shoulder blades will start on the bench, then you'll reach up, bringing the shoulder blades off, and lower back down under control. With this, the goal is to keep the same width in between the weights, meaning they are not getting wider, not getting closer, and we have a smooth and fluid motion up and down off of the bench. Now, we can take this into a larger range of motion by adding a press. We can make this a very segmented motion with 4 individual parts: press, lower, down, up, or we can make it one fluid motion where we incorporate all of it together. We can think about doing one arm at a time, with the focus of not only going through the full range of motion with the moving arm, but having to stabilize the top arm or the stationary arm. With this, they are not able to use each arm as a counterbalance, so it can add a little bit more complexity and challenge from a coordination and from a stability standpoint. Medicine ball throws may be introduced towards later phases of rotator cuff rehab to focus on how well the shoulder can perform, but also tolerate higher speeds of movement. Now, with the medicine ball throw, there's a lot going on. It's a little bit faster, a little bit more aggressive and violent of a motion, but what the arm is actually doing is similar to the motions that it went through with our serratus punch and with our pressing activity, meaning the hand starts close to our chest and it finishes away from the body. We have the arm going from a bent to an extended position, but we also have the shoulders finishing in a more rounded reaching motion. There's a variety of different ways that you can do medicine ball throws, where you can just start stationary and have them press directly away from their body into the wall, or you can add a stepping motion where they start with feet together, take a step, and press into the wall. So keep in mind, with all of these exercises, the early exercises are more basic in regards to the motion they're going through and the amount of resistance they have, because we're in a healing phase. We want to re-educate the muscle, we want to protect that healing tissue, but we want to get them moving in a tolerable way. However, if we do this strategically, we can use early phase exercises to set some of our later return to sport phase activities And that allows the athlete and the individual to really paint a picture as to how early phases correlate to late phase goals. Rotator cuff injuries are common orthopedic injuries that we deal with in physical therapy. Thankfully, we can get great results with conservative care and post-operative care if you get surgical intervention. The key is to remember when you have the injury, make sure that you are working with all of the appropriate information and resources at hand. Consult with a physical therapist, consult with an orthopedic, figure out if imaging or any definitive diagnostics are necessary, and then make sure everybody's on the same page with the injury that you're dealing with and what the expectations are moving forward for your individual plan of care. Hope that you enjoyed this video. If so, like, share, subscribe, and stay tuned for our next one on the labrum tear.